Hello and welcome. I'm Nancy Nealon, Community Program Manager for the New York, New Jersey chapter of the Parkinson's Foundation. I'm very happy to welcome you to New Frontiers in Research and Care, PD Generation. The slide you're looking at right now tells you about the critical goals of the Parkinson's Foundation. And I'd like to say our mission is to make life better for people living with Parkinson's by improving care, advancing research towards a cure, and making sure that we mobilize everything on behalf of the Parkinson's community. Please know you can also get in touch with us for our multitude of resources, from many books, podcasts, our hospitalization kit. We have many centers of excellence and our great website and helpline. Please utilize both in all of these to get whatever you need to live your best with Parkinson's. I'd like to take just a moment to thank our wonderful sponsors who made this presentation possible today. First, our first silver sponsor is Medtronic, and I'd like to give a big shout out to them and their incredible team. Thank you so much for your generosity. It is very much appreciated. Thank you so much. And our other silver sponsor is Acadia. Thank you so much for all the folks at Acadia for supporting our critical mission and all that we do. So that's not a lot of time to tell you how to learn more about our wonderful sponsors. So please go to our virtual exhibit hall. You can find that at this link. You can go to parkinson.org/New York, New Jersey. And once you're there, you will see our chapter supporters link. Please visit that link to find out more about our wonderful sponsors, Medtronic and Acadia. Now, without further delay, it is my honor to introduce our very esteemed speakers today. We are so lucky to have such a superstar lineup. It's truly amazing. First, we will hear from Dr. Susan Bressman. Dr. Bressman is recognized for her pioneering work identifying genes for dystonia and Parkinsonism. Her current research is focused on identifying diagnostic and progression markers and disease pathways for Parkinson's disease, especially the LRRK2 and GBA genetic subtypes. Dr. Bressman attended Columbia's University College of Physicians and Surgeons and received her postgraduate and fellowship training at Columbia's Neurological Institute. Following Dr. Bressman, we will hear from Dr. Rachel Saunders-Pullman. Dr. Pullman is the chair at the Bachman Strauss School of Medicine at Mount Sinai and professor of neurology at Icahn School of Medicine at Mount Sinai. She is a clinician, educator, and clinical researcher. Her research focus is the study of genetics and epidemiological factors relating to Parkinson's disease and dystonia, with focus on the elucidation of new genes and interaction between genes and development of predictors and markers of PD and dystonia. She is the program director for the Overall Movement Disorders Fellowship for both Sinai's programs. And lastly, we will hear from Deborah Raymond, who is a genetic counselor at the Bonnie and Tom Strauss Movement Disorders Center at Mount Sinai and is based at Mount Sinai, Beth Israel. She received her master's degree in genetic counseling from Sarah Lawrence College and is certified by the American Board of Genetic Counseling. She has been responsible for supervising and coordinating family studies aimed at understanding the genetic causes of movement disorders, as well as providing genetic counseling for patients seen in the Department of Neurology for over 20 years. So there you have it, our very, very well-esteemed presenters for today. And at this time, I'd like to turn it over for Dr. Susan Bressman to take the lead with her presentation.
So
Can
you see my screen?
It will be here probably in just a moment. There's always a bit of delay, or can be. So why don't you give it another try, Dr. Bressman? Zoom sometimes can be very tricky to navigate.
Okay, so let's see what we can do here.
We'll get it figured out. Would you like one of us as a backup to share your slides? Oh, no, here we go. You've got it.
Can you see it?
It's coming. So we're very close.
Are we good?
We are good. You were excellent.
Yay!
Thank you. Yay. Take it away.
Okay. All righty. So thank you so much for inviting us to talk about our center and to talk about P-degeneration to this wonderful group of patients, family members. And I'm going to start by talking a little bit about, give you an overview of our center's approach to Parkinson's disease, a little background into Parkinson's disease, and then how we, over the years, over some 20 years, have incorporated genetics into our care of patients and how it's really transformed the way we take care of patients. So what is a Center of Excellence? We were a National Parkinson's Foundation Center of Excellence, now a Parkinson's Foundation Center of Excellence since 1995. So we've been doing this for a long time. And what makes the Center of Excellence excellent is that it's a team. It's a team approach. It's no single one person. And it's a team of experts that are really dedicated to providing state-of-the-art care. What does that mean to people with Parkinson's disease? So first of all, it's making an appropriate diagnosis, a precision diagnosis, as we'll talk about as we're learning more about the causes of Parkinson's. And that includes potentially genetic counseling and genetic testing. So we try to incorporate that now pretty much all the time in how we, when we make our diagnosis and when we first meet our patients. We also have a multidisciplinary team. So it's multidisciplinary treatment. That includes lifestyle, exercise, psychological and social support, which we try to provide, and treatment approaches both to the motor problems that people with Parkinson's have and non-motor problems. And because of that, because it's a wide spectrum of problems, it includes expertise in psychiatry, neuropsychology, physiatry, ENT, speech and swallowing, developing relationships now with GI and urology, cardiology, and sleep. So there are all kinds of problems that may or may not develop, but to be able to provide those services. And this could include behavioral interventions, medications, surgery, botulinum toxins, so a wide variety of treatment approaches. And then, of course, engaging our patients in research, educating about research, about trials that are available, observational and interventional trials. So let's talk about Parkinson's disease. Most of the people listening in today know a lot about Parkinson's disease, but it is a clinical diagnosis. As I think most people are aware, you come into the office, there's a history that's taken, and then we do a clinical exam. And what we're looking for, the hallmark feature, is slowness. So whether it's slowness getting dressed or walking or with handwriting, that is a key clinical feature. Rest tremor, people focus on the rest tremor, that's often present, not always present. And muscular rigidity. We move arms and legs around and we try to check for people's tone. So it's a clinical exam. We have people tap their fingers and tap their toes. And people say, is that how you make a diagnosis? And it is. That is the state of the clinical exam. We look for asymmetry. And the other part that usually doesn't happen at the beginning, but as we take care of our patients over time, is a response to L-DOPA. And I'll talk about that a little more on the next couple of slides. Over time, as we follow patients, other problems can develop, including postural problems or balance issues, and also non-motor issues. What are these non-motor issues? Problems with sleep, problems with mood, problems with constipation. So those can be features, and they can be pretty important features of Parkinson's. And so we need to pay attention to those problems as well. And what's really interesting to us, and I think we didn't pay attention to this 20 years ago, but we do now, is that these non-motor problems can precede the motor problems. So that made us start thinking that when we see a patient with Parkinson's, stuff has been happening in the brain for years before. And that actually gives us a window, and I think Dr. Saunders-Pullman will talk a little bit about that, to intervene earlier, because we have these clues that something's going on. So part of the diagnosis, we have to exclude mimics. Imaging can be helpful. There's no magical imaging tool, but sometimes we'll use DAT scan. That's looking at dopamine in the brain, dopamine transporter, and we look for asymmetry. And here's a DAT scan, and hold on, let me just let me hide that. So you can see that normally you have like good signal on both sides of the brain, but in Parkinson's disease, that signal gets diminished and it's asymmetric. So with genetic testing, that's another thing we can do as well. And Debbie will tell you a lot about counseling and what testing can show and not show. But we don't have a specific sensitive test that says this is Parkinson's disease. And we don't have a way other than, our clinical exam to measure what's going on in the brain. Is there damage to the brain progressing? Is it staying the same? Is it improving? And if we're going to intervene to really get at the cause of Parkinson's and cure Parkinson's, we need that. The other issue with Parkinson's that I think you all know is there's heterogeneity. No two patients are the same. If people say, if you've met one patient with Parkinson's disease, you've met one patient with Parkinson's disease. So there are different clinical pictures, but there are also different causes. So there's heterogeneity at both levels. Hold on. Okay. And this is a little cartoon to just show you that levodopa, L-dopa is our gold standard treatment because it is those dopamine producing cells in the brain that are affected in Parkinson's disease that aren't producing sufficient dopamine. So we have to get that we have to try to replace that. And we do that with L-dopa, with Symptomatic is the brand name that I think most of you have heard before. Dopamine can't cross the blood-brain barrier, so we do it as dopa. Patients ask this all the time, why don't you just give me dopamine? No, we have to give you dopa because dopamine won't get into the brain, and your body will want to metabolize that dopa, so we give enzyme inhibitors to keep dopa as dopa, and then it gets into the brain, and it's in the brain that you have that conversion to dopamine. And our therapies are really, many of them, surround this whole dopamine enhancement mechanism. So we use direct dopamine agonists, we use enzyme inhibitors, we fiddle around with the different connections, dopamine connections to enhance that effect. Okay, so current symptomatic medical treatments, we have a lot and we keep getting more and better treatments. So, we have levodopa, we've had that for many, many years. Dopamine agonists, we've had those for many years as well. They directly stimulate the dopamine receptor. We have enzyme inhibitors that enhance your own dopamine. So we usually start patients on some sort of pro-dopaminergic medication. And over time, we may need to augment those therapies. We can add to levodopa various enzyme inhibitors, or amantadine, another drug that many of you have heard about. There are also new drugs on the market like estradefylline, and also other versions of levodopa. So the way you give Symptomatic now, it needs to get into the stomach has to empty, it has to get into the small intestine. And so there can be a delay and incomplete absorption. So wouldn't it be great if we could get levodopa directly into your bloodstream? So now we have an inhaled version of levodopa and also a dopamine agonist, apomorphine, a very potent dopamine agonist that you can take sublingually. So, and we're working on other mechanisms as well to avoid that delay and incomplete absorption. So depending on what somebody's problems are, and their patient profile, what patients prefer, other problems that a patient might have, blood pressure issues, bladder issues, we'll sort of try to pick the best medication. But some patients the medications are insufficient, don't really take care of the patient fully. So we go to device-aided therapies. And the one that most of you know about is deep brain stimulation, which can be quite efficacious. There we directly stimulate the circuits of the brain to sort of override the dopamine deficiency, and they can be very helpful for selected patients. Also, continuously levodopa infusions. So working on other and improving and perfecting these other treatments. But we need to think about the non-motor features as well, because the levodopa is great for the motor problems, but what about the depression? What about the constipation? What about the bladder issues? So we have to address those issues as well. And we have many therapeutic approaches. We're not going to talk about that today, but there are many available approaches for these non-motor problems as well. So we have the medical approach, and then the non-pharmacological therapies. Physical therapy is key. Exercise is key. We can talk about that at the end. Right from the beginning, we encourage our patients to exercise, to work with physical therapists, trainers. Speech therapy can be very helpful as well, and occupational therapies. So we have a spectrum of treatment approaches. We're improving them all the time, but we still want that cure, or that intervention that slows progression, okay, potentially reverses pathology. Okay, so what do we know about the etiologies of Parkinson's? Because if we're going to look for this cure, we really want to understand the mechanisms and the causes. So over the years, it's evolved from thinking it was shock, fright. Right from the beginning, people knew a subset had looked like it was inherited in families. Then there was now we're living in the age of COVID. There was the influenza pandemic of 1918, 1919. And that was followed by a post-encephalitic Parkinsonism. So people started to think about viruses and post-encephalitis, and could that cause Parkinson's? And that was clear that there were people who had that, but there were other people who never had the flu. So we started to then look at other causes, or this inherited subset of patients. And as we were looking at that, there were some drug addicts who had overdosed on this meperidine analog, Demerol analog, and they came down with severe Parkinson's, very acute, severe Parkinson's, young people. And it was clear that took a while to figure out that there was this toxicant, MPTP, that was destroying their dopamine cells. So that again started a renewed interest in environmental toxicants, which we can talk about at the end, which are important, and people are thinking about this as well. So and then there was a debate. Neurologists love to debate. Is it environment? Is it gene? Is it both? What's important? Well, we started to discover genes that predisposed to Parkinson's in the late 1990s. And that really opened up a whole new world of understanding of Parkinson's. And I'll show you a slide in a little bit that just shows you the timeline of that. But we realized that genes were important. They really contribute, and they can contribute in a very important way, but relatively rarely. So this shows you genetics, this shows you environment, and then the gene environment, this epigenetic overlap. So all important. Oops, let me just go back. This just shows you a timeline looking at Parkinson's etiologies, environment, genetic, and how recently we've discovered these various genes, starting in 1996 with alpha-synuclein. And then you can see here Parkin, DJ1, LRRK2, GBA, which you're going to hear a little more about. So we identify these genes that can be really critical players in bringing on Parkinson's disease, and then these risk alleles. So what's the difference? What's the difference between LRRK2, alpha-synuclein, and these risk alleles? So sometimes a genetic cause that we identify, let's say in a family, can be determinative. You have that change in your genome and you're going to develop Parkinson's. And it can be dominant. In other words, you only need one copy and you're going to get the Parkinson's. And let's say alpha-synuclein, certain mutations in alpha-synuclein can be like that. It could be recessive, meaning you need it from both. You need a copy from both your parents to develop Parkinson's like that. And you're going to get Parkinson's at some time in your life. Rare, but it can happen. Then you have these genes that markedly increase your risk. They're not determinative, but they greatly increase the likelihood that you'll develop Parkinson's, but not 100%. And GBA and LRRK2 are two examples of that. I mean, with GBA, maybe, 5%, 10% of GBA mutation carriers will develop Parkinson's, the rest won't. Why won't they? So rather than a 1 to 2% risk in your lifetime, you may have a 5 to 10% risk. So significantly increases it, but not determinative. LRRK2 is higher, maybe 25, 30% chance you'll develop it. But again, 70% of people don't. So what is the other factor that either protects you or precipitates the Parkinson's? We don't know, okay? And then you have the complete environmental determination, and the MPTP was the example I gave. Other complication here is that these genes are not the same in all populations. The frequency of these mutations are not the same. So in most populations, if you look at genetic contribution, maybe 10, 15% of people will have like one of these major genes. But if you're Ashkenazi Jewish, it's more like 35%, maybe higher. So, and if you're African Berber, over 40%. So there's a difference, another complication in, when you think, do I have one of these genes? And now to talk more about the genetics and more about the research, I'm going to turn it over to Dr. Saunders-Pullman. Is that happening? Can you hear me?
It will be happening. It just takes a few moments to switch
good.
over. We'll get there.
Good. Okay.
Thank you, Dr. Bressman.
And Dr. Saunders-Pullman, you could share your slides now.
Fantastic. Thank you. Do you guys have my slides now?
Yes, it looks great. Thank you.
Okay, super. And I am so fortunate to have worked under the leadership of Dr. Bressman. You've heard her talk, and also with my colleague Debbie Raymond, who you'll hear from momentarily at Mount Sinai for the past 25 years. And this is a picture of our group. Does my arrow show?
Yes, we can see it.
Okay. All right. And our part of our terrific team, and as I said, you'll hear from Debbie shortly, and our focus has been on providing expert, compassionate care, as well as cutting edge translational research with the primary focus on genetics. And because of time, I'll spend most of my allotted time trying to put the genetics into context further, and also why this new Parkinson Foundation PD generation study is important. And then if there's time in the questions, we'll also be happy to talk more about the particulars of some of our research at Mount Sinai Beth Israel, Mount Sinai. So I want to start by emphasizing, as Dr. Bressman has noted, that no longer is it just the same medicines that your father may have had with Parkinson's. We do have a lot of treatments to help the Parkinson's symptoms. And these are shown in this big blue circle. And not just many formulations of levodopa or L-dopa, which is the heart of most of the movement problems, but also trials with patch pumps similar to insulin pump that are on the way. We also have a range of medications. Although we have this range of medicines, we really, as Dr. Bressman mentioned, need medications to slow or stop the progression of disease and also reverse it. And these are what we call these disease-modifying therapies in green. And I'm going to focus my talk on understanding how genetics may lead and help us be successful in trials for disease-modifying therapy. And there are a couple of reasons and ideas as to why the trials for disease-modifying therapies haven't been successful yet. And one is that we need better targets to change with medicines. And the genetic forms of Parkinson's, especially alpha-synuclein, LRRK2, and GBA, give us better targets. LRRK2 is a gene that Dr. Bressman spoke about, and on an individual basis, someone with Parkinson's with a LRRK2 mutation can't be distinguished from someone without a LRRK2 mutation except by the blood draw with genetics. And when we think about LRRK2, there are several changes called mutations and different ones, and these are highlighted up here. And although they have different effects in the protein that the LRRK2 gene directs, so the gene directs the synthesis of this protein, they all share an overall common effect, and that is to increase the protein kinase activity. And these kinds of protein changes are considered what we call very druggable targets. They're easy or to develop drugs to treat. And there are several ways to block LRRK2 kinase activity that are in early stage trials right now and that are very exciting. And I've shown some of these, the antisense oligonucleotides and the small molecule agents. And then for GBA, which we also heard about, the protein that is made by the GBA gene is also exciting because, well, it's an issue mostly of not enough rather than too much like LRRK2, there's at least 5 different ways to modulate it, including, as I mentioned here, gene therapy, as well as chaperones to help the protein get into the right place in the cell, and medicines that activate the proteins. And one can also replace the lowered enzyme, although there are some challenges with this as far as crossing the barrier from the blood to the brain. And another way that trials may not have worked is that they may have been underpowered or not had enough participants who are likely to respond to a therapy. And some of this is because of problems with heterogeneity, as Dr. Bressman talked about. And genetics allows us to combine more similar groups to increase our odds of finding a successful therapy. And I'll explain this idea by showing you some superheroes. I think we've all been watching, or many of us, too much Netflix or other stuff. But just to bring up one of our oldest superheroes is Superman. And by analogy, we think we know that Superman is susceptible to kryptonite. So the idea is that he has this weakness and susceptibility to kryptonite. And I just showed some other superheroes. And then for fun, I added my dad, who had Parkinson's, as one of my own personal superheroes. And this slide shows that even if we have a good medicine to block the kryptonite and help Superman in a study with a treatment and a sugar pill, which is the way we do our trials generally, if there are only a small number of people who respond to the treatment who end up in the treatment arm, even though it's a good kryptonite blocker, the study is not going to show benefit because there's not enough difference between the treatment and the placebo. On the other hand, if there are a lot of people with this kryptonite weakness who get the drug, then the study is much more likely to show a difference between the treatment and the placebo arms. And to this point, as we think about alpha-synuclein, it's interesting that the genetics in alpha-synuclein mutations are very rare, still can give us information and lead us to other trials. So even if you don't have the gene, such as I pointed out here, some of these Wonder Women and Black Panthers, we can get lucky. And if we put the right proportion of them who are still susceptible to synuclein agents, we may still have benefits. So it is very important to find new genes and understand these genes and discover the differences in different people's Parkinson's. And so this slide shows a big range of synuclein trials that are going on. And they're not just for regular Parkinson's disease, but also for multiple system atrophy, some of the atypical Parkinson's. And then another big way that genetics can help is to provide biomarkers. And I have been so very lucky to work not only with Dr. Bressman and Debbie Raymond on the genetics research, but a fantastic team of translational researchers, clinicians, basic scientists, and not only from Mount Sinai, but from Columbia, Dr. Smarter and Alcalay, and from Tel Aviv, especially Dr. Giladi and Anat Mirelman. And we have been systematically trying to understand both LRRK2 and GBA to really gain a foothold towards trials, design the best therapies, and towards this idea of when can we get towards disease-modifying therapies and a cure. And one example of our work, and I'm just going to show two brief examples, is from the combined LRRK2 Ashkenazi Jewish Consortium. We've been able to show that the change in movement scores, this is a unified Parkinson's disease rating scale that Dr. Bressman talked about with the finger tapping and so forth. And what we've shown is that the change in the UPDRS in LRRK2 Parkinson's is slightly less than people without the mutation. And this is really important information for our colleagues in pharma when we're thinking about designing clinical trials. Another thing that we've looked at is smell as a possible biomarker for Parkinson's and LRRK2. And this has multiple ramifications, including that, as Dr. Bressman mentioned, smell might be abnormal before the development of Parkinson's, and it helps us understand heterogeneity even within LRRK2, that we have people, the smell test is a scale to 0 to 40. We have, even with LRRK2 Parkinson's, people who have a very good sense of smell. And this is a little bit different than regular Parkinson's, where most people have a lot of problems with smell. So biomarkers help us in teasing out and understanding these differences. But there's still an awful lot of gaps. We need more biomarkers to help move the research forward, such as including understanding this concept of reduced penetrance that Dr. Bressman talked about, the fact that most gene carriers with LRRK2 and GBA never develop Parkinson's. And biomarkers can help in other ways too. There is ongoing research to understand biomarkers and other genes. It's a little dark here, but I'm trying to show that we have this gap and that research helps us bridge this gap. And I want to highlight, if you'll forgive me to plug our NIH study that we're doing focused on markers in people of Ashkenazi Jewish descent, so Eastern European. And if you're interested in the study, please reach out to our genetic counselors, Sonia Longo, Deborah Raymond. And the goals of our study are to not only understand the effects of LRRK2 and GBA, but also to identify new Parkinson's genes and better understand the role of immune cells in Parkinson's. And our samples are shared with the National NIH Parkinson's Disease Biomarker Program. In addition to our study, there is also a new PPMI study that is starting and many other studies, including PD generation, which we'll hear more about. And resources to find studies include the Fox Trial Finder and clinicaltrials.gov. And I also want to briefly plug a study from my collaborator, Inga Peter, who is looking at the microbiome in Parkinson's, as we're understanding that the gut plays a role potentially in the beginning and the starting of Parkinson's. And certainly, as Dr. Bressman also mentioned, we know that there are often a lot of non-motor issues with Parkinson's that may include constipation, and that affects the absorption of medicines and many other factors. So another potential gap and a barrier that we faced in testing medicine first in genetic Parkinson's before bringing out to a larger Parkinson's community is, will we have enough carriers and will everyone have access? And as Dr. Bressman pointed out, the frequency of LRRK2 mutations vary significantly across different ethnic groups. And indeed, the frequencies have been studied in many ethnic groups. And I love this slide from Dr. Lesage, but forgive me, I did not translate the French here. But certainly we know in different areas frequencies, but In some populations, we still don't know. And if you don't look, you won't find it. And for example, we by chance noticed an increase of LRRK2 G2019S mutations in our Puerto Rican patients. And now there are initiatives to evaluate genetics in underrepresented populations. We have a study sponsored by New York State trying to improve education and counseling. And of course, the PD generation study should help with this as well. And people who are interested in our study, I also put the contact for Sonia Longo here. So in sum, genetics may help us to get to better disease modifying therapies, but there are still some gaps to bridge. So please consider being part of the answer to bridging them. And I want to send a very special thanks to those of you who have been part of our studies and to our sponsors, and also to thank you all for taking the time to join today. And please continue to stay safe. And now I want to introduce my colleague, Debbie Raymond, who will explain more about genetic counseling and testing, as well as talk about the PD generation study.
Okay. Hi, everybody. It's a pleasure to be speaking to you today. And I'm just going to bring up my slides. Okay. So you've been hearing a lot about the genetics of Parkinson's. I am a genetic counselor, and so my job is to speak with patients about Parkinson's genetics and some of the aspects related to genetic testing. And I'm going to go through with you some of the conversation that I have with patients. And so just starting with some basics, genetic variations dictate who we are, from eye color to disease diagnosis. And genes are the instruction manual for the formation and activity of proteins. So genetic mutations are also called, which are also called variants, can change proteins, and this may play a role in disease, as you've been hearing. Now, our genes are strung together into structures called chromosomes, and that's what you're looking at in this picture. And you can see that our genes and chromosomes come in pairs. Each parent passes on one or the other copy to their children. And in most cases, Parkinson's increased risk is associated with having a variance in one of those copies, and that's called autosomal dominant inheritance. And as you've heard also, most people who have a risk gene for Parkinson's will never develop symptoms. However, in rare forms, there is a mutation in both copies, and that's called autosomal recessive inheritance. Now, one way to think about Parkinson's risk is through this diagram. You can think of it as a jar that gets filled up over a person's lifetime. So if we are all born with a jar, and the blue beads would be genes that you're born with, and the gray beads would be environment and lifestyle that happens after you're born. And once the jar gets filled up to a certain point, that's when a person starts developing symptoms of Parkinson's. Now, as you've also heard, it's rare for somebody to have a purely genetic cause for their Parkinson's disease, but that situation is represented here on the upper left of the slide, where the jar is filled to the top with the blue genetic beads. But most Parkinson's disease looks more like these other three examples, where there are varying degrees of genetic components, but where environment is also very important. And conversely, just because you have some of the risk factors for Parkinson's disease, it does not mean that you're going to develop symptoms. So as you've been hearing, we know we've advanced our knowledge a lot about the genes that cause Parkinson's disease, and we've identified some of those genes. But overall, we actually only know about only about 10% of PD patients will have a variance in a known gene. So what about that other 90% of cases? And what are the lifestyle factors that influence Parkinson's risk? And so there's clearly a lot that we still don't know about the causes of Parkinson's, and all of these studies that we've been talking about so far, as well as many others, are trying to get a handle on these other causes and questions we still have. Now, you may be thinking about having genetic testing, and if you are, the choice to learn your genetic status is a very personal one. You can speak with your physician about options and also get a referral to a genetic counselor. So why is genetic counseling important? Isn't this just a blood test? And actually, when people start thinking about genetic testing, there are many questions that come up. Of course, the risk to family members, who do you tell when and how, should your kids be tested? Is this going to help your doctor with your treatments and your diagnosis? And these are the kinds of things that we talk about and go into when we do genetic counseling. So genetic testing is similar, but also different from other diagnostic testing. And there are pros and cons. So we do get information about the person, but of course, there's also information that relates to family members. And there are different considerations depending on who is being tested. For example, a patient versus a family member, early versus late onset Parkinson's, because different genes cause different types of Parkinson's. And your ethnicity matters because you may be more or less likely to have a mutation in one of the known genes based on your ethnicity. There are also many gray areas and misconceptions about genetic testing. And some people ask, does my negative gene test mean I don't have Parkinson's? Or does my negative gene test mean that my Parkinson's is actually not genetic? Some people ask, does my positive gene test mean that I'm going to get PD? And of course, the answer is no to all of those questions. And then also results may be difficult to interpret. So that may require a discussion as well when that occurs. So why do people choose to be tested? And people naturally want to know what the cause of their symptoms is. They're interested in risk to relatives. And a lot of people are actually comforted by the fact that most people who inherit a gene don't develop Parkinson's. People don't always know that at the outset. And it can give information about some information about the natural history and management of the condition. But really the biggest reason right now is that it does impact research participation because of the gene-specific trials that Dr. Saunders-Pullman discussed. There are also drawbacks to testing, and it's definitely not for everybody. Some people feel guilt about passing on a disorder, and there's a burden to potentially to information because we can only test right now for the known genes, and only most, but not all of the changes that can occur in these genes. So a negative test, as we were saying, can still mean that the PD may still be genetic. But the gene wasn't able to be identified using this test. And then results can be equivocal. So that can be, disconcerting for people as well. And then some gene changes may not impact management. And some genes don't have any associated trials yet. In addition, testing can be complex, and there may be a follow-up testing that's required. And for people who are unaffected with Parkinson's, they may worry about the impact on life and disability insurance because we still need better laws to protect us from discrimination with those types of insurances. And that leads me directly to the PD generation study, which is really fits in well and is so exciting, because through this study, the goal is to provide genetic counseling and testing for those who are interested. And it will be offered to a very large number of people, up to 15,000 participants. It will be offered in English and Spanish, which is exciting. And the genes that will be tested will include LRRK2 and GBA, as well as a number of other important Parkinson's genes. Now, this is still a research study as well. So DNA will be banked on participants, and that will help in the study of the other genetic factors that we still don't know about. It's a 5-year study that was initiated in 2019 and has so far enrolled over 600 people. It is being done, as you heard, at Parkinson's Foundation Centers of Excellence, as well as Parkinson's study group sites. And if you are interested in participating, of course, we would love to hear from you, and you can do this by either contacting your neurologist or going to the Parkinson's Foundation website and enrolling online, where you'll be asked a few short questions and you'll be connected with a site to schedule your appointment. So with that, I'm going to turn it back over to Nancy.
Thank you so much to all of our fantastic presenters. And as you might imagine, we have, I think, wonderful questions. Such a challenging field for those of us, obviously, as I goofed up a few words at the beginning. So I'll try and do my best here. But let's start with some questions from our participants that I think will probably be so important for us to understand. One person writes in, and I guess I will pose this to Dr. Bressman. So is there any known effect between PD and the World Trade Center fallout? Would the World Trade Center fallout be an environmental cause for PD? Are there any studies on this? Could you address that?
So I'll ask Rachel and Debbie if they know. I don't know of any good study showing an increased risk from the World Trade Center and Parkinson's that's been unequivocally shown to be the case. And I know there are lots of groups, including Mount Sinai, that has been looking at the impact of the World Trade Center on health and disease in Lower Manhattan. So, Rachel is there? She's looking.
Yeah, not that I'm aware of, and we have close colleagues who are involved in this study, so I will reach out as well, but I don't think that we've established any association.
Yeah, I know people were looking at it and trying to establish, and I think they're, in terms of the coverage and the law covering diseases in Lower Manhattan, they did not include Parkinson's. So I think there wasn't sufficient data, but I'm sure there's still some people looking at it long-term. Yeah.
Yeah, absolutely. Very good. Thank you. Someone else writes, how can I get involved in a LRRK2 trial? And what's the timeline looking like for development, approval, and ultimately something in the market? Who would like to take this one?
So I can say I'm, and I think Dr. Saunders-Pullman knows this as well, but I've been in communication with one company, Denali, that I know has done some studies looking at safety of some agents they have that affect the LRRK2. So they think it's hyperactive, and this sort of decreases the activity, which they think, based on different models, will help with the disease progression in LRRK2 patients and even potentially gene carriers who don't yet have Parkinson's. So I know they're looking at their protocols, and my understanding is that they will start recruitment at the end of this year, but don't hold me to that. That is sort of the rumor that I've heard. I don't know if Rachel has heard more.
No, I think that the timeline is definitely still a rumor. I would say it is very important to look at the clinicaltrials.gov website. So our study and others that are observational research, really trying to get the important information that will really help make sure these trials are efficient. We not only have to have the trials, as we emphasize, we have to make sure they're going to work and be successful. And but the Denali, so as Dr. Bressman talked about, the kinase inhibitors are primarily through Denali Biogen, Denali, and the prior studies are posted on the clinicaltrials.gov. And then as we get to the small anti-nucleotide oligosense, that also those studies will be coming up. I don't know a timeline for those though, as far
No, that I haven't heard, but I know the Denali work is proceeding, and I know they do anticipate having a real clinical trial. They've been talking about it for a long time, and I guess nobody wants to say exactly when they're going to start recruiting, but that one is for real, and I think that will happen. Yeah.
And one of the questions will be just this whole issue about LRRK2 carriers, at what stage and how long they've had Parkinson's, and then whether also, because there is a question that LRRK2 maybe play a role in other Parkinson's as well, whether the study will include people even without LRRK2 mutations.
Thank you. And I think this is the next question actually is not surprising whatsoever. I'm so glad someone asked this. So we've had such a speedy development of COVID vaccines. Why not with Parkinson's? Can you discuss or talk about the challenges that are associated with all this?
Wow, that's a good question. And that's a philosophical question too. I think some of it is scientific. In other words, some of these companies, based on other viruses, were set up to go. This whole thing of using messenger RNA, and using these adenoviruses, that technology was there. Okay, that was already developed. It was just getting the key piece of the COVID virus, that spike protein piece, and deciding that that was going to be the target for the vaccine. But so the pieces were in place. There was loads of money and people were dying. So countries came together. Listen, companies came together to do this. So there was, a major push to do it, but there was the technology and the target, pretty much they knew what target they wanted. So Parkinson's, we have a bunch of different targets. And, COVID's COVID, it's one virus. Parkinson's is heterogeneous. It's a bunch of different causes. Do we target alpha-synuclein? Do we target these genes? Do we target inflammation? Do we target the lysosome, the protein, how we recycle proteins? So, it's a little more complicated, and it's been harder in the previous trials. We've had plenty of trials to try to see if we can help, modify disease progression, and they haven't been productive. They haven't been positive. They've been productive, we learned, but we haven't really identified an agent. And as Dr. Saunders-Pullman was saying, some of that may be because we have too many superheroes. We haven't targeted the right superhero with the kryptonite. Is that right, Rachel? Did I use that metaphor? I don't know.
I hope I used it correctly, though. And I think, this is we for years have had the war on cancer. And the issue is we haven't gotten to the cancer cures that we wanted, although some subtypes of cancer, it's been phenomenal as far as the progress. So I really, it's very, very frustrating, but I do feel like if we can really build on the strides in the technology, that there is a lot of hope and promise for this. And so, yes, it's a big challenge and we have to meet it now because people with Parkinson's have it now. We've got to move it forward. And I am very hopeful though.
And I think identifying these gene risks, genetic risks, have been critical. Yeah, no
So
question.
I
Yeah.
think the technologies also, even though things in different fields are apparently unrelated, really, they can really accelerate. And it may not be this linear thing. We may hit a jump. I mean, and this is that philosophical question about how progress is made and what happens. And even some of the vectors, as far as thinking about delivering the vaccines, are also similarly used in gene therapy trials to deliver Parkinson's genes. So there is really this cross-fertilization across different fields, and I'm hoping we'll be able to really capture and work with those technologies to bring things forward.
I mean, we have a gene trial for GBA coming up.
Yeah.
So this is introducing into the spinal fluid of our patients the normal GBA gene. So and if that expression of that normal GBA protein will overcome the mutation and modify disease progression, potentially even restore. We don't know till we do the study.
It seems by virtue of all that you have shared, to me, it's why PD generation is so important, that's going to help move us forward tremendously. And I'd like to just focus in on a few more specific genetic counseling, genetic questions. So Debbie, did anyone ever ask you about their concerns about submitting their genetic information, and how is it protected from people who are perhaps a little nefarious, or corporations selling people's personal genetic information? How do you address that with people?
Yeah, so that is definitely a concern that people have. And, there, when we do research, we have many ways of protecting people's privacy, and we're really very, very, very careful and focused about that as much as possible. And so research is a little bit of a different situation than when we send testing outside of research to a clinical lab. So we kind of separate those two. But of course, the labs themselves are also required to stick to standards of confidentiality and so on. And so when we think about the risks of potential problems with confidentiality, we are especially concerned, or more concerned, about people who are being tested who don't have the condition, because the sense is that people who have Parkinson's and are being tested they already have Parkinson's in their records. So having, for example, an insurance company know that you have a gene for Parkinson's may not change your ability to be covered much more than the focus on the Parkinson's as far as the insurance.
Okay.
But with people who are unaffected, and there's no mention of any kind of disease in their record, sometimes they'll be more concerned about, for example, life or disability insurance, because while the laws protect people from discrimination against being denied health insurance, the laws just aren't in place for the other insurances. And so that is something that people should think about when they're considering testing.
And if someone has had genetic testing done, perhaps commercially, or what's the difference with PD generation compared to perhaps something available in the general population?
Yeah, so PD generation is part of a research study. So by virtue of being under the research umbrella, your personal information does not your contact information is not shared with the laboratory. You're basically a number with the laboratory. And when the report comes back to us, we do get an actual written report from a lab, but it'll just have the number that's associated with your record. And the only point to think about there is that if anything that you do share with your medical provider may get into your medical record. And so even though you're coming into this as through a research study and you're protected as far as the lab having your information, once that information enters your general medical record, it's in that realm of being part of your record and part of your.
But the other thing is the
information.
direct to consumer available testing really only tests for 2 mutations, right?
Yeah.
That's my understanding.
Yeah.
So that's a huge difference too. I mean, you only learn about 1 mutation in LARC2 and you learn about one mutation in GBA and not the others. So I think it's limited. So when people do 23andMe, I mean, they get their information, but they're getting, I don't know if they understand fully, they're getting limited information, not the whole picture.
Right.
Plus they have to pay for it.
Right.
Plus their
Which,
DNA belongs to a commercial company.
right. So,
Yeah.
so this is free.
So
the genes tested are much more extensive. And the other big difference is that people who participate in PD generation have access to wonderful genetic counselors like Debbie. So it's that additional step to help people understand the results. Would
Yeah.
that be a correct statement?
Yes, in
Yeah.
fact, I was saying I saw a patient the other day whose son had done 23andMe, but really knew there was a risk, but didn't know the gene, didn't know what it meant, didn't understand reduced penetrance. So got a piece of the information, but not the whole picture, including, so I think that is a huge difference in terms of educating the patient or the family member, really, learning, which is what our counselors do. Yeah, sure.
Absolutely.
And just if I could just emphasize that the genetic counselors also, and genetic testing does also offer the option of testing even beyond the Parkinson's panels. Sometimes people will have testing of other genetic conditions, and one can go to what we call whole exome and whole genome testing as well. So the spectrum is expanding as far as potential possibilities if there is Parkinson's in the family and it is not one of these Parkinson's mutations is not detected on the panels.
Very good question that just came in. Let me ask, because I think everyone would want to know this. So how invasive is PD generation? What's involved? And is there a difference because of COVID versus pre-COVID?
So Debbie,
So that's a good question. And thankfully, there, as far as the COVID question, you can do this study either in person or virtually. So if you're, if you're somebody who prefers not to come into the clinic, that is an option for you. And so it's very easy and not very invasive because all you're doing is providing a blood sample or a saliva sample for the test. And you'll be doing some questionnaires, but there's nothing invasive in the study.
So before COVID, folks were going to an actual site and going through the protocol, having blood drawn. But we've made a big adjustment because of COVID, and that is you can do this from your home. And it's a cheek swab, is that correct terminology? Saliva swab, is that correct?
Yeah, so it's either a saliva or a cheek swab.
Okay. So I guess it depends on your definition of invasive, but hopefully not too invasive.
Right.
I'd like to get a couple more questions in here, and I'm going to be very basic about this one. Someone asked, has there been any study to see if there's a correlation between people with Parkinson's and being positive for MTHFR FR mutation. My mother has Parkinson's and she has the MTHFR mutation, as do I. Could you just
So,
follow up on that, explain that a little bit?
yeah, so basically, the MTHFR is methyl tetrahydrofolate, which is in the folate metabolism, which is a pathway that now is being screened as far as this approach with what we call pharmacogenomics. So the question is, if you have certain genetic mutations, do they predict your response to certain medicines? And we're hoping to also go in that direction as well. It's another part of the larger puzzle we're looking at as far as how much the genetics help. And here, often it is looked at as far as how people will do with some of the medicines for depression and anxiety that work on the serotonin system and in that pathway. And there is work to look at the association with this. And I'll let Dr. Bressman step in, but I'm not sure that we can establish any clear link with that with Parkinson's. And just because one has that, the methyl tetrahydrofolate reductase polymorphism does not, at this point, I think we're not, that there's a clear increased risk. With
No, not that I know of. When you look at the different risk variants, I can look again, but I know that doesn't sit high on the list in terms of changing your risk for developing PD or determining what kind of Parkinson's you're going to have. But you're right, it is important. People are looking at this in depression for sure, and trying to figure out, and also how it affects your response to medication. So, but I think people are definitely looking at, that whole pathway is important, and we think about it a lot in terms of treatment and best treatment for patients and PD risk. Yeah.
And this will be our last question for today. I think it's another very important one. And let me qualify that by saying, clearly we just don't have time to get to every question. Please utilize our helpline, 1-800-4PD information. Go to our website, parkinson.org. We're happy to follow up with you on any of the questions that we didn't get to. So our last question for today, spouse writes in that her husband is veteran who has Parkinson's due to Agent Orange exposure. Would he be a candidate for any of these studies?
So good question. For the genetic studies that I know right now, I think they are targeting gene carriers. They may include non-gene carriers, which Dr. Saunders-Pullman was alluding to, because we think these gene therapies may benefit non-carriers. But for other if we think this is Parkinson's disease and that it shares pathology with Parkinson's disease, then I don't think that would exclude you from these trials. Each trial is very specific in inclusion and exclusion criteria. So you have to, each study is different, but I am sure that for certain studies, he could be included. Rachel, you're looking up this,
Yes, because I didn't want to speak too quickly.
No, because I'm not sure.
I agree. But I did find a study from 2019. So what happens is when you get these tests back, they don't necessarily, they'll often tell you, sorry, so we're going back to the prior question. If you'll
because it's a tricky
just because we want to make sure not to give anybody misinformation.
Right, exactly.
So I do agree with Dr. Bressman on the current question as far as I don't think we're excluding Agent Orange related Parkinson's. But to get back to the prior question as far as the methyl tetrahydrofolate reductase, is that I did find one study which showed a particular polymorphism might increase the risk of Parkinson's. And this is that question gets back to the very beginning of Dr. Bressman's talk as far as, and something I tried to allude to too, is just even if you have the gene or you have something that triggers that's a strong risk factor, it may be that other things really boost so that you then do develop Parkinson's. So there may be some role. I think it's really not well teased out though, but I
Yeah.
have to apologize.
Oh, about that, yes, because people have looked at that repeatedly because potentially it could contribute to Parkinson's. So it's been a
Exactly.
variant of interest. So I'm not surprised, but I don't think people don't think of it as a big player the way we think.
Yeah,
of
it's exactly as you said, Susan. I just wanted to.
GBA. But I think that with the future actually is we still have more genes. We have so many families that don't have GBA and don't have LRRK2. So we know there are other important genes out there, but also this gene and gene environment interaction. So you're exposed. It's like COVID. Some people get COVID and nothing happens. Other people get COVID and get so sick. So I think when we think of Parkinson's, it's complicated. It's the host and it's the environment, and that interaction is important for sure.
We could certainly be here all day. I have no doubt. The very positive thing, because we can, is that, and we are so thankful for all of you being on the PD Generation team. Thank you so much for the presentations today. Thank you so much for participating and being one of the sites and helping us to pursue our mission. So thank you all to all of our speakers. Very important to have you with us today. And I just have a couple more things to share with everyone before we officially sign off. And of course, the first is to say more officially, thank you to Dr. Susan Bressman, Dr. Rachel Saunders-Pullman, and Deborah Raymond, and to all of you who joined us today. You will receive a follow-up email with a survey. Give us your feedback. We so need that. We so appreciate your feedback. You will also receive a link to the presentation and get other resources. So thank you to all, and thank you to our sponsors, Medtronic and Acadia. You are so wonderful. Next, I'll highlight once again the importance of PD Generation. You can call our hotline, our helpline. You can go to our website, PD Generation. We need as many people to participate for the success to helping us get to the bottom of Parkinson's. And I will also give a plug for another program that I'm involved in. It's PD Health at Home. 3 programs, live programs every week: Mindfulness Monday, Wellness Wednesday, and Fitness Friday. Please join us. We'd love to have you participate. And lastly, we're very pleased to announce that we are going to have a moving day. Moving day is a walk for Parkinson's. It will be virtual, but it's centered right there in Westchester County. Please check it out. Visit movingdaywestchesternewyork.org. You'll find out a lot more. Get a team together. We would so appreciate your support. Thank you again to everyone. Stay safe. And if you have any questions, contact our helpline or go to visit our website. Thank you.